Could you leave this here? Are you going to walk around?
30 years ago now. Yeah, almost 30. I started in a hospital in New Orleans, and we dealt with a lot of the indigent and homeless, many of whom were elderly, many of whom had mental health issues. So these are things that we're going to talk about, are some of the challenges of aging, and those can be health-related. They can also be resource-related. Many times they are. So as a primary care provider, many times you find yourself working with these individuals and dealing with their health challenges, but also balancing their resources, because many times their health problems are a direct result of resources. Let me give you just a few examples of that. One of those is, and I think of this patient because she's been with me in my practice for a really long time, has congestive heart failure. And I saw her for a number of years, and pretty much the end of every winter or so, she would go in the hospital with congestive heart failure. What I failed to talk to her about is what she was eating during the winter time. You ever think about what we might eat in the winter time could be challenging if you're on a limited income? She was loading up on tomato soup. And have you ever looked at the back of a tomato soup can? 750 milligrams of sodium. And that also coincided with the time she reached her donut hole in her medicine. So she was taking medicine money that she normally spent on food, spending that to get her medicines for the month because she was a very compliant person. So she made a decision between eating and taking her meds. It didn't dawn on me until just a few cycles of this to ask her about that. And that's when she shared with me that saltines she could get for 78 cents a box at Walmart when they were on sale. And she could get 5 cans of tomato soup, and she could live really well off that. But guess what that meant for her in terms of her congestive failure and in terms of ending up in the hospital. So that might not be something that's on your usual assessment if you pull up your electronic medical record. How many cans of tomato soup were you eating? It wasn't on mine, anyway. So those are all things that we have to think about. So we become not only managers of healthcare for these individuals, but also managers of resources. So just keep that in mind as you're talking with these individuals this afternoon. Okay, let's see if we can figure out what's going on here. So hopefully all of you had a chance to look over the PowerPoint before we get started today. These are just a few of the things we're going to seek to do as a part of our exercise today, and as we talk a little bit about elderly clients in the primary care setting. Typically, the geriatric client is going to be one of your more complex patients. In fact, if you've already been in your clinical setting and you've talked with older adults, there's usually not just one thing wrong, is there? It's usually a multiple list of things that are wrong when they come to see you. And the other thing that's really important to remember about the fact that they're very complex is that if you attempt to focus on one diagnosis, as we often do in episodic care, we might really miss the whole reason for them being there. So part of what we'll be doing as we assess geriatrics this afternoon is to try to really distill where their biggest challenges are and which ones are really the priorities. One of the most important ways of doing that is to find out how their health care needs or their health issues are impacting daily function. Because in older adults, we don't, as we might treat a younger person and cure something. With older adults, it's more a management of chronic conditions to maximize quality of life. And that's a really important fact to remember when you're working with older adults. It's not about healing, it's about helping them achieve quality of life. We can't add quantity, that is, we can't add years to their lives, but we certainly can work toward adding quality. So most of the time, we're not going to fix their problems, but we're going to try to do everything we can to maximize function. 45% of the people that are age 65 and older are not living in institutions. So while we've seen just a huge expansion of the number of nursing homes, upscale independent livings, and upscale assisted livings, still a lot of people live in their own homes. And I know in my own practice I have patients who are in their 80s and 90s who still live independently at home. And some still drive, which is scary in some cases. But they do, and they still function very well in life. I have some who live in independent living, and there's one in particular that I think that she's 105 years old. And she has 2 medicines that she takes, and she's on a walker. Her hearing is not quite what it used to be when I first started caring for her, but she never fails to tell me that I need to hurry up because she has a date. So, yes, and I told her she was robbing the cradle because most of the gentlemen she dates are in their 90s. So, very interesting situation that we find ourselves in this country. In fact, only about 5% of Americans that are over 65 live in a senior care setting. So when we think about all these individuals who are still living at home, our goal becomes really successful aging. We know we're all going to get older. We wake up every day, we're a day older, and someday we'll reach that. There's always I think, a huge impact when I go to visit someone and I look at pictures of them that they have hanging on the wall of when they got married, when they had their children. And then you see these later pictures, and you see the person before you who looks very different. That's the thing I will tell you about that, and I think sometimes we fail to notice because we don't know these people, maybe their whole lives, is that the person on the inside is still the same. Though the package on the outside looks very different, the person on the inside is still the same. And it's very much an honor to be chosen as a steward of all those memories in someone's life. I always like to think of my older patients as treasure chests, because they truly are, because you become a steward of all those memories that they've collected over however many years they've been here. So while we look at the package on the outside and it may be wrinkled or crumpled, kind of looks like Christmas paper after all the Christmas is over, you're still a very young person on the inside. And I know while some of you are much younger than I'm starting to realize that myself, that even though I might feel 20, my body's not 20 anymore. And I've had to make some adjustments because of that. And so when you look at your patients and you see that wrinkled person who can't hear or can't see so well anymore, remember there's still a young person on the inside that still has many of the same wants and needs that you do. And I think sometimes we tend to lose patience with older adults, but try to keep that in mind as you talk with them. Very few people escape having some type of disease process. I mentioned my little 105-year-old patient, who's really the exception to the rule. We know as we get older, especially as we look at the CDC disease maps, that a lot of our choices lead to unhealthy aging. And you look at the obesity maps. How many of you have ever looked on the obesity maps at CDC? Ever looked at those? If you look back historically over those maps over the last 20 years, you can see how the South has gotten progressively more toward the red side. So we're getting fatter and fatter as we get older. And we know from that things happen as a result of our body weight going up. Just interestingly, I read, of course we all know about cardiovascular disease, which is one of the most extensive processes. But the other thing that goes up as a result of obesity are cognitive impairments. We know that as the body fat increases, brain mass decreases. Isn't that interesting? There's some recent studies that talk about that. So the decisions that we're making today and the fried chicken that we put in our mouths today become our health problems of tomorrow. So one of the things that we have to do, especially with our clients, especially those going into their 30s, 40s, and 50s, is to really work on health maintenance and talk about nutrition and lifestyle changes. Those are not shortcuts that we can afford to take anymore. We used to pass over those, gloss over those, but now they're becoming critical because they come at a time when our country is undergoing radical changes in reimbursement and radical changes in the amount of health care that's going to be available to everyone. So these lifestyle changes, maintenance, become very, very important. When we think about age-related physiology, we obviously know that the person, as they get older, their appearance changes, their mobility changes, and their capacity to ward off infection changes. That's one of the things that we see, an increase of cancers in older adults. That's why many of our screening things like mammograms, colonoscopies, all those fun things take place around the ages of 40 or 50, because that's when we start to see a somewhat rapid decline in muscle mass and the ability to ward off disease. And our body fluid composition changes as well at that time, so that our medications don't are not as effective as they once were. Let me give you a really good example of that, because this is a pitfall for many providers. For those of your patients who have hypertension, many of those, as they get older, the number of receptor sites change for those drugs. And as they do, antihypertensives, just one type of medicine as an example, may start not to work. And so the first inclination of the provider is to go ahead and increase the dose of the med, right? But if you don't have receptor sites for those medications, what can happen? It's not going to work, is it? So we may find ourselves in a situation where we're perhaps beating up the liver or causing a toxicity situation and not really addressing the problem. So if you start to see that change in the way a patient responds to meds, very often we may need to try a different class of drugs or a combination of drugs. You may have noticed some of the drugs that come out, like Benacar, Azor, some of those that are combination, and they're specifically directed at the older individual whose receptor sites have changed. So those are just some things to think about as you move into your management classes. I know you're not quite there yet, but it is something that you can begin to notice in your clinical setting and start to think about as you move into your management classes. One of the first things that we all notice as we get older is the thinning of the epidermis. Skin becomes very dry and uneven. Pigmentation changes. I had freckles when I was young. I looked like that kid that's on Orphan Annie. That's kind of what I looked like when I was a little girl. And the freckles kind of went away as I got older, but now I see that I've got them coming back. So that pigmentation from aging starts to come back. The skin, we start to lose the vascularity of skin and that elasticity that's there. There's a decreased amount of sub-Q fat, and so wrinkling begins to be more prominent. One of the things that is interesting, if you look at the literature about wrinkling, is that people wrinkle differently, and that's actually a genetic pattern. So you can look at individuals within your family, your mom, your aunts, people like that, to see what your wrinkle pattern will look like, which I think is very interesting. I'm getting some kind of, oh no. Well, so not interesting. Perhaps it's a predictor of the future. Maybe you won't be happy about that. There are changes in adnexal structures, so sweating, growth of hair, and nail growth can be something that can be challenging for the older adult. We start to see the increase of the toenail fungus. You've noticed that in older adults, the really thick toenails, because our immune system decreases and because cellular changes take place. They're more susceptible to those kinds of problems. We also see more bruising in older adults as the skin begins to thin. The elasticity, especially in women, is due to the decrease in estrogen as menopause comes along. So that's a problem. Older adults too are at very much increase for overheating and getting over cold because their body temperature regulation changes and their ability to sweat changes. And so people can get too hot. If you work in Deep East Texas, you have some of these folks that get out and do a garden every year, and they can quickly get overheated because their body's sweating mechanism doesn't work the same anymore as we get older. So that's something definitely that becomes a part of our health teaching. Changes in neurosensory function, people's response time to cutting themselves, they may not even realize in some cases, especially if they have conditions like diabetes. We may see the onset of peripheral neuropathy, so they may cut themselves and not realize it. I've had individuals who, in my practice, and I always look at the feet of diabetics, especially older diabetics, you can find nails, tacks, things stuck in the bottom of their feet, and they don't even realize they're there. And they can have horrific sores between their toes and not realize they're there. And as the vision decreases, they're not able to perhaps clean as well between their toes. So you see an awful lot of toe jam in older people. You want to make sure that you look at that, because between that and underneath that gunk that gets between people's toes, and this particularly if you have people coming in from who are cared for at home, unless somebody's specifically drying between those toes and looking, you can have ulcers that occur as circulation decreases, as the ability to feel or sense pain decreases. Individuals may not even know that they have sores there. So it's always important to take those shoes off and look very carefully at that. The iris becomes more rigid in the eye, and decreased night vision is a common complaint for older people. Many people start to see vision changes in their 30s and 40s, but by the time we're much older, this becomes even a greater problem. So certainly something that you need to make note of as you're working with older adults is their ability to see. And talking about eye exams, that's an important thing to ask about, especially if they're wearing glasses. How often should someone have their eyes examined if they're wearing glasses? Yearly. So that becomes part of your health maintenance in working with older adults. If they come in wearing glasses, you want to make sure that they've been to see the doctor. There's a decreased number of rods and cones in their retina, so their visual acuity is going to change. There's decreased elasticity of that lens, so they're less able to accommodate. And so their near vision declines, so reading becomes difficult. One of the things in working with older adults that I do is to take something that's 12-point print for them to read. And if they're not able to focus on that and read, then it's, I know it's probably time for them to have their eyes examined or have glasses changed. The other thing that is important along those lines, especially if you're working with these nursing homes or other senior care settings, is make sure there's some provision for making sure that someone's glasses are clean. Older adults can't see the smudge on their glasses, and a lot of falls can be caused because people can't see. And it can be as simple as cleaning their glasses. We'll talk about ears in a minute, but that's the other thing, is to make sure that we're maximizing their sensory function as much as possible. I had an individual, an older gentleman, who came to my office recently, and he was complaining of hearing loss, and his ear was full of wax. So those are kinds of things that you need to be really tuned into as a primary care provider. As people age, the ear membrane becomes much thinner and sclerotic, so we start to see more impaired auditory function. The ossicular chains, little bones in the ear, may calcify, so there's a loss of sensitivity to high-pitched sounds. Middle and lower tones are sometimes affected. So what does that tell you about in communicating with older adults?
Talking a lower voice.
You want to talk in your lowest tone. Not way up here, because they're not going to be able to hear you. So you want to pitch your voice as low as you can, and try to speak very, very distinctly and look directly at them. So that means in working with older adults, if we have electronic medical records and we have a computer screen in front of us, that they may not be able to hear what we are saying, or they may not perceive the question that we're asking. So it's very important for them to see you and not be distracted by the computer screen. What you may be asking may not be what they're hearing. So you may get some odd answers. Just as an example of this, going back to the gentleman with hearing loss, he had been diagnosed with dementia. What happened when we cleared out his ears? He could hear just fine and answer all those questions on the mental status exam. So he had been given some medications that he didn't need to be on. He was on Aricept and had just started the Mendet, but he couldn't hear. So when we asked him what year it was, he would stare at us because he didn't realize anybody had even asked him what year it was. So always make sure before you pronounce someone that they have cognitive impairment, make sure that their sensory function is maximized. So that goes back to that whole looking at function. While we may not be able to give them back the eyes they had at 20 or the ears they had at 20, we need to make sure that we maximize what we're doing for where they are right now. We also see decrease in the salivation and also of olfactory cells in the nose. And this sometimes leads to hydration or impairment of hydration and also impairment of nutrition. If we can't smell, do we get hungry? No. What sets off that chain of hydrochloric acid in our tongues? It's mostly smell, isn't it? It's like when we chew a piece of spearmint gum, what happens? Get your salivary gland going. You smell that spearmint going through your nose. It smells so good. Or a nice piece of chocolate. Wonderful glass of wine. It's a lot of it's about the smell. So if we start to lose the sensation of smell, then very often we start to see the weight drop. So older people can start to lose weight because food just doesn't taste right anymore. And a lot of this can be created too by medications that they're on. Many of the medicines that they take are anticholinergic, which means they're very, very drying. So if we dry up other parts of the body, i.e. we add to an already decreased capacity for salivation, we're also affecting diet and nutrition. Do you see why? So these are things to think about as you look at that person, the older person in your practice. Right now, many, at least the ones we can study, many of the folks in assisted living or senior care settings are on anywhere from 12 to 14 medications a day. That's a lot. Many of them go through the same pathway, so they're affecting liver, kidney, and we affect those functions of already decreased functioning organs, in addition to many of them drying out the mouth and affecting nutrition. So you can see how by inappropriately managing or over-medicating individuals, we can sometimes create health problems for them and decrease function. Teeth are another one. Periodontal disease is one of the main causes of tooth loss, so much so that now nursing homes are required to have a contract or relationship with dentists so that these abscesses, things of that sort, can be treated and that proper dentition can be assured. Overclosure of the mouth can begin to be a problem and cause what's called an angular cheilitis, just because the bite is off. The other thing I would say is people begin to lose weight. Dentures don't fit right anymore. And that's one of the things that you want to make sure you look at as a part of the older adult assessment, is looking at how dentures fit. If somebody's lost 20 or 30 pounds since they had their dentures fitted, what's going to happen under those dentures? We're going to start to see abscesses. We're going to see sores in the mouth. We're going to see decreased nutrition as a result of that. It's so important for dentures to fit correctly, so that in addition to eyes and ears, be sure you're looking at the mouth. Look really good under those dentures. You know, some of them use this polygrip stuff, but make sure that they know that you're going to examine their mouth, because that's a big source not only of pain and infection for older adults, but we also know now from the literature that those with poor hygiene in the mouth can be at risk for increased infections in other places in the body. Teeth can be a source of potential sepsis for the older adult. So it's definitely something that we need to pay attention to. Dentures are interesting, and if you work in the nursing home setting, they become even more interesting. I'll have to tell you, I want to tell you a story about dentures. It was happened to me a long, long time ago. And there was a gentleman named Bill, and he walked around pushing his wheelchair all day long. Bill had a little bit of dementia. And I was working as a consultant in this nursing home at the time. And one day I came in and we were having a state survey. And so Bill was walking around as usual and pushing his wheelchair, and he decided it was a good idea to pick up everybody's dentures. So as the state surveyors were going through the community, Bill had his laundry bag. And he was just walking along the hall like nothing was going on and just kind of wandering in and out of people's rooms like he always did. But the thing that was different was that Bill was picking up everybody's teeth. So we have just kind of, we're getting everybody up for AM care, and we'll start looking for their teeth, and we couldn't find them. And here the state surveyors sat. Well, nobody knew, because all the dentures on the hall where Bill lived were gone. So we looked and we looked and we looked and we looked, and of course the surveyors were looking at us like, yeah, right, you're really putting dentures in these people's mouths every day. And it occurred to one of our CNAs to look in Bill's bag, and guess what we found? We found everybody's teeth. The bad thing about it is that none of these teeth are labeled, and so we didn't know whose teeth were whose. So we incurred a $1,000 a day fine until we could get a dentist out there to refit everybody's dentures. So dentures are very important. Okay, let's talk a little bit about endocrine. The other thing that is really important to think about with older adults is the decreased secretion of the thyroid hormone, insulin, and growth hormones. So this is something that really has to be monitored with the older adult, particularly as we see a cellular decrease in hormones as people age. One of the things that we find in practice of geriatrics is that with older adults, sometimes just a subclinical low with a thyroid can cause major problems for them in terms of cardiac status, in terms of their ability to metabolize drugs, and to control body temp. You see these little ladies that are wrapped up in blankets. Sometimes it's due to a subclinical hypothyroid condition, not always, but many times we know that thermoregulation changes with age, but a subclinical low. And by that, I mean when you see the TSH, let's say your range is, depending on your lab, is 0.5 to 4. That's a big range. But if somebody is at 3.9, everybody knows that as TSH goes up, that's thyroid stimulating hormone, that means we have closer to a hypothyroid condition. When thyroid stimulating hormone goes up, it means we're not producing enough. So even with a subclinical low, let's say that you have an older adult and the range is 0.5 to 4, and they're at a 3.8, that may not be the right level for their thyroid to function maximally to meet the needs of their body. So we might go ahead and treat even though they're not outside that lab range. Always remember that you don't treat the lab, don't treat the diagnostic, you always treat your patient. And that's true whether it's an x-ray, If I were to show you today an x-ray of my mom's knee and ask you, do you think this person needs a knee replacement? You would say yes. And if I were to ask you further, do you think this patient looking at this x-ray can walk? You'd say no. And in both cases, you'd be wrong. So we always treat the patient, because clinically, my mom functions just fine with a knee that looks like it should have been replaced 20 years ago. But she's not in pain, she walks, she does fine. But to look at the x-ray alone, if we were to treat that, we would refer her for a knee replacement. It looks that bad. So it's the same thing with labs and with older adults. Again, we're not going to necessarily fix things for them. We want to manage them optimally. So sometimes that means we have to really consider the whole patient when we look, particularly at a thyroid lab, because that can make a huge difference in how they feel. When someone's hypothyroid, what kind of symptoms might we see? Tired, cold, gain of weight or loss, heart palpitations, can affect cardiac status. So there are lots of things, swelling of the lower extremities goes along with that. Lots of things can happen because that's a major regulatory hormone. So it's something that has to be considered in that differential. What else would we think about that might cause similar symptoms in an older adult? I know you're not in management yet, but we're just kind of moving a little bit. What do you think about? Tired, short of breath, cold? What do you think about? Anemia, absolutely. So your differential for that person would be hypothyroid and anemia. Very good. So that's what you start thinking about as you think about function in the older adult. Okay, let's talk about cardiovascular. With the older adult, because we know that the percentage of fat changes and the percentage of muscle changes in the body, what do you suspect might happen to the heart as it gets older? It gets kind of bigger and floppier. In some cases, depending on function in earlier times of life, it can become more stiffened, or we might see stenotic valves. That means they become very stiff. The heart, as a young heart, it pumps very efficiently, effectively. The muscle is very, very strong. There's a lower percentage of fat. As people get older, the heart becomes typically larger. It has to work harder. The valves begin to stiffen in the heart, or become stenosed. We see left ventricular wall thickness, and we start to see systolic pressure go up a little bit because of the heart's additional effort to support the needs of the body. Along with that, vascularly, we see decreased elasticity in the vascular system. So as the heart is becoming larger and floppier and less effective in its feed, our vascular system becomes less functional as well. There's an increased thickness at the base of the aortic cusp. Lots of fibrous tissue. Calcification starts to follow, and we see aortic sclerosis. The valves, as I mentioned, become more stenotic, and that's why we start to hear murmurs, right? Aortic murmurs. You start to, one of the baseline tests that we do in our practice is to get an echocardiogram, so that we can kind of get a baseline at about that 50, 55, 60-year-old mark, so that we know what those valves are like, so that when that person is 5, 10 years older and starts to have problems, we know what baseline looks like and then what the changes look like. EKGs in older adults are not that useful. Echoes are very useful because we know what the changes of aging are. Valves, the other thing we see is increased stroke volume with progressive exercise, and that's when you tend to hear more murmurs. It takes longer for the heart to recover post-exercise. An S3 sound is generally pathologic in the older adult. So if you hear that S3, S4's sounds are often present and otherwise healthy older adults. However, as we mentioned, there's left ventricular enlargement, so it suggests decreased ventricular compliance and impaired ventricular filling. Mitral valves are similarly effective. Calcification may occur, the closure becomes hard, and we start to hear that mitral regurg that's going along. And it's important at this point, remember how we talked about checking for bruits. It becomes critical in the older adult, because this is when you start to see carotid bruits, as these can indicate atherosclerosis and obstruction, which can, of course, affect cognition. As far as the lungs, the chest wall starts to stiffen as people get older. Respiratory muscles begin to weaken. Those diaphragmatic muscles begin to weaken. There's a decreased elastic recall of the lung, and we see decreased sensitivity to changes in the levels of O2 and CO2. Of course, this becomes even more severely compromised if the person has a chronic lung disease like COPD, as an example. The cough is much less effective, and we also see decreased ciliary action in the lung. So as a result of that, we start to see an increase in secretions. There are more infections because that's coupled with your immune system function dropping in its effectiveness. And this is also, in some individuals, we start to see this thoracic curve of the spine known as kyphosis. That also decreases your lung capacity and the ability to take a deep breath. And that should make all of you want to sit up straighter, right? Everybody, get your chest back. Wings back. There's increased AP diameter, barrel chest, and generally they can still have a pretty good O2 sat, but if they have COPD, we can start to see decline. One of the other things that is the bane of many people's existence, and you'll find this if you work with older adults. They, did we lose our thing? You never had it to start with? Oh, that's terrible. Where am I today? Wake up, Dr. Peterson. Okay. That's better, isn't it? Okay. The other thing that becomes problematic for the older adult is GI function. As the GI tract ages, the motility becomes much, much slower. So what becomes the focus of the older adult's life? Bowel movements, constipation, and many of the meds that we give them, what did we say they did? They dry people out. We're not drinking as much. So what happens? The gut slows down. So that puts older adults at risk for impaction, constipation. So as you add medication, one of the things you're going to need to ask about or think about is, what am I going to do for bowel function for this person? So this is when we start, and we're talking about the 12 to 14 medications that people end up on. What would be your suspicion that some of those meds would be? Stool softeners, laxatives. Okay. So those are some of the ways in which we start to see that med list growing. We also see decreased absorption, so there's a decrease in the amount of B12, iron and folic acid. The most common type of anemia that we see in older adults is iron deficiency. There's anemia of chronic disease, but iron deficiency anemia is probably the number one thing that we see as far as anemias in older adults. We also see, and this is one of the lab tests that you would want to think about in older adults, is a decrease in the amount of vitamin D in the system. What does vitamin D do for the older adult? Cognition, calcium absorption. What happens if we don't absorb calcium? Osteoporosis, and that's coupled with, especially in older women, menopause, which when estrogen goes away, we start to see bone loss. We start to see compression fractures in the spine. So that vitamin D becomes even more critical around the time of menopause. We also see similar, and I'm sure if you've driven down the freeway or been in a reasonably moderate-sized town, you've seen these low T clinics, low testosterone clinics. You've seen the ads on TV. The other thing that happens in older adult men is they lose testosterone. We start to see a loss of muscle and bone mass. So they become at risk also for osteopenia and osteoporosis. So these are things to think about both in your older men and women. They found, if you read in the literature, we find that men who lose 2 inches or more of height after age 60 have an increase in cardiac events. Why do you think that might be? Any guesses? There's one out there. Don't be shy. Do you think it's due to the loss in height, or do you think it's due more to the lack of calcium? Yeah, exactly. So electrolyte balances change, and so we start to see less effective muscle in an older, floppier heart. We also could see some more compression on that due to loss of height. So lots of things to think about that. There's also a narrowing of renal vasculature. So this is the age where glomerular filtration rates become very important to us. In men, we see the decreased testosterone and a decrease in penis size, and the testicles tend to drop lower. You start to see benign prostatic hyperplasia in 50% of men. So the prostate gets bigger as they get older. So that prostate exam, when do we start that? 50, 45 with Afro-Americans who are at risk. So erectile dysfunction becomes a problem. If you turn on the television at all, we see these male enhancement drugs, the herbals. That's something to think about as you talk to people about their medications. They may not consider, especially in older adults, you'll find that they don't consider herbals or vitamins as medication, or even Tylenol. Medications are only the things that the doctor or the nurse practitioner prescribes for you, and things over the counter and things you buy off TV don't count. So part of your assessment becomes having the person bring to your office that brown bag of medications and vitamins and herbals that they take. Why would that be important? Interactions, yes. If, for instance, if someone's taking ginkgo biloba for their mental status, that can affect your PTI-NR, right? What else can affect PTI-NR? Coumadin affects it, but I mean, what in terms of vitamins? Vitamin E, all these omega-3s, overdosing on vitamin E. So those kinds of things can be important to think about. Men who have erectile dysfunction, these herbals that many of them are buying over the television or over the internet in some cases actually will have erectile dysfunction drugs like Viagra in them, because there's no FDA regulation of these medications. And so they're coming from India, they're coming from Canada. We have no idea what are in some of them. So if they already have cardiac problems and you're taking these herbals, they can certainly run into some problems with that. The average age of menopause, and this will be important for you to remember, for women is 45 to 52. You may have hot flashes that last up to 5 years. That is a very common complaint of women in this age group. Sleep disruption is not uncommon. Mood changes are probably the most common. And then vaginal dryness and dyspareunia or painful sexual activity. So as estrogen decreases in the older female, we start to see some of the skin changes that I mentioned to you earlier. We see bone loss, and we may start to have hot flashes that crop up as a complaint in our clinics. There are lots of different ways of dealing with that. Hormone replacement therapy was once something that was pretty common Now people think about that a little bit more. They're not so ready to jump on that. And certainly if there are cancer risk factors, not everyone is going to be the appropriate candidate for that. But we can use antidepressants. Those sometimes are used. Prestige is one that's often used. So there are lots of different ways of dealing with that. But certainly it's part of aging. Incontinence becomes also another event that is sometimes unexpected and unreported. That's an embarrassing thing for people, isn't it? And so if we, as a part of the review of systems, it's definitely something that we want to talk about. Yes, ma'am?
Is it common to find heavy bleeding for women right before the onset of menopause?
Do you commonly find bleeding before the
Heavy bleeding.
Heavy bleeding?
And changes in their menstrual period, because like where I had my rotation over the semester,
Mm-hmm.
most of the women actually with complaints of heavy bleeding
Mm-hmm.
were right about that age range.
Okay. The question was, do you sometimes see heavy bleeding as menopause approaches? And the answer to that is yes, you do. Menopause is actually diagnosed when there's been an absence of a year of periods. That's how you diagnose it. And of course, you can run lab tests if you have concern or somebody is prematurely in menopause to see if there's something else going on with them. But menopause itself is diagnosed, and usually in that 1 to 2 year out, because there are changes in the way the hormones rise and fall throughout the monthly cycle as someone ages, and we move away from being able to ovulate and those sorts of things. The body's response to that is to build up a heavier lining. So sometimes when people go 2 or 3 months and they don't actually have a period because of that lack of cyclical fluctuation of hormone, then you'll see very heavy periods or clots. And sometimes the periods will be very irregular for a year or two. Sometimes people will spot just a little bit, and then they'll go 2 weeks, and then they'll have a really heavy period. So there's a lot of changes in the way that the period presents itself. So yes, it's not uncommon to see that. They'll have a real heavy period, and then it'll go a while, and they won't. Eventually it stops. But there can be a couple of years there where things are very rocky for them. They start to typically have the night sweats and hot flashes along with that sort of thing. So it becomes a very uncomfortable time in life for them. And reassurance and also teaching is very important. In spite of all the women's magazines that are out there, there are many people who still don't understand menopause when it hits them. It's kind of unexpected in some cases. Many times, and because a lot of women in this generation, many of their moms had hysterectomy. At one time, the hysterectomy was the answer to everything. And so they don't know when their mother went through menopause because they didn't. So you may find that with some of your patients now. And typically people in siblings in a family or the mom and her daughters will similarly have menopause onset within just a few years of each other. So you can kind of help somebody learn about themselves and what may anticipate that by what's happened in siblings or with their mom. Incontinence, along with that, though, is very common, especially in older women. We know now that episiotomies that were once pretty routinely done and still may be in some areas may actually not have been the right thing to do. As people get older, that pelvic floor becomes weaker. One of the things that's very important with your female patients, regardless of age, is to begin teaching about Kegel exercises. It's very critical to their aging and can help offset some of the early onset of incontinence. If someone comes in and tells you when they cough or sneeze, they pee, they're well past the time when you start Kegels. Kegels are started when you're 21 years old, and you keep doing them throughout your life. A good goal that I give to my patients and my older patients is to tell them not to try to stop the flow of urine, but to go ahead and void urine. And then once they're done with that, to do 20 squeezes before they get up, every time they go to the bathroom. And what that does is to start to strengthen that pelvic floor. Now, if someone comes to you and incontinent, and you want to find out what kind of incontinence it is, so we'll spend more time with that in your management classes in the fall. But finding out what kind it is, and also getting them to a specialist. There are NPs, and I have a good friend in Houston who is actually an incontinence specialist. She does work with biofeedback and different sorts of things like that, and also places pessaries. There can be a lot of different causes of incontinence, and so the first thing is to find out why that's happening, and to help the person deal with that and give them some thoughts about how they can at least deal with it until they can come to some solution for it. It affects their self-esteem. Social life, you find that there's onset of depression, people really lose an interest in activities or have a fear of going out because of this issue. And I actually hate this mnemonic, but part of the assessment that we were talking about of causes is very important, and it's the doctor's mnemonic. I don't typically share that part of it with patients, but it's one that you can keep in your head. Delirium, which you may see in older adults if they have a urinary tract infection. You may see a sudden onset of confusion or behavioral change that happens just almost overnight. So delirium. Infection is another thing that sometimes causes incontinence, so checking urine for infection. Atrophic urethritis or vaginitis, and again, as estrogen leaves, the other thing that leaves is the elasticity of the vagina and those structures there. We also see an increase in the number of urinary tract infection because along with the loss of estrogen in the vaginal tract, we start to see a decrease in pH and a decrease in lactobacilli, which keep the vagina clean and keep us free of infection. So as those things go away and estrogen leaves, then we start to see an increase in urethritis and vaginitis as a result. Pharmaceuticals, if we give somebody Lasix, what's going to happen? They're going to pee, okay? So that can certainly cause distress. In fact, you find people who quit taking their Lasix or their hydrochlorothiazide because of that. They don't like what happens to them when they take it. Excess urine output, restricted, and that can be certainly secondary to diabetes that's been undiagnosed. Restricted mobility. If it's hard for you to get up out of your chair and get to the bathroom, that's another one. Or if it's hard for you to speed to the bathroom to go, then that can be a problem too. The other thing, and we talked about this earlier, is stool impaction. If somebody has impacted stool, that puts pressure on the bladder and the urinary structures, and certainly can cause increased incontinence. As people age, there is naturally a loss of height due to the thinning of the discs, and the vertebrae begin to collapse from osteoporosis if we've not got a handle on that. We have an increase of kyphosis. As people get older, these little, just draw this, not a great artist, but we'll kind of pretend this is a spinal column here. So we're drawing our little spine. And in between these are the disc pads, and there are also some little, what we call facets, little hooks that kind of keep the spine aligned. Those wear, as we twist and pivot over our lifetimes, those wear off to some degree. The disc will wear completely out in some cases. If we've had like a back fusion, and let's say we have a back fusion at L2, L3, or whatever, surgical intervention there, or discectomy, everything below that begins to wear more as a result of that. And so the back, actually, you'll start to see more and more wearing of the disc below that point at which it can't pivot. So you actually end up creating issues. Sometimes it's very necessary when people have fractures of the spine, but everything below that we know is going to wear out. So we start to see arthritis of the spine. We start to see discs that are shifted or herniated as a result of that. And we may start to see, if they are osteoporotic, we'll start to see compression fractures of the spine, where these these little facets will chip off, and we'll start to see just an erosion of this whole area right here, especially once these discs are gone. So compression fractures and pain become a big issue for the person that has osteoporosis and then sees vertebral collapse. If they do that from front to back, which we expect, then that's when we start to see the kyphosis. As those discs erode, you start to see that bend right in the upper back. And that's what actually causes the kyphosis. As we see this decreased bone volume, we also start to see fractures. And there's always the question of whether someone has a fracture and falls down, or whether they fall and fracture something. Just an example of this, I saw a resident walking across the dining room, and she suddenly went down. I believe it was a spontaneous fracture because her leg gave way and she went down. So when we x-rayed her, she had crumbling in this femur, which I don't believe happened as a result of her fall. So she crumbled and then she fell. And that happens. You see that. This happens in the spine, so people who have compression fractures from the weight of the body on that spine, sometimes we'll see that. So there's, as a result of that, and the lean body mass, the muscle that's replaced by fat, we start to see osteoarthritis develop more in these older individuals, and a real decreased range of motion. We start to see the onset of use of walkers, wheelchairs, those sorts of things. The one thing that's really important to remind your patients as they enter their 30s, 40s, and 50s is to continue walking and using like weight-bearing exercise, because that's the one way to ward off some of these issues. Not all of them, but some of them, because it keeps the bone stronger. We know that if we increase the load on bone, that it will continue to reproduce. As we become more sedentary in our habits, our bone mass begins to decrease exponentially. So the more, there's an old adage, because if you don't use it, you lose it, is very true with bone development. So continuing to walk and to utilize your body to preserve muscle mass as much as you can, and also to do weight-bearing exercise is very important. We know that brain volume also decreases as we get older. How many of you have heard of shaken baby syndrome? Everybody heard of that? Okay, so you know that if the baby's shaking, the brain bangs around inside the skull. A very similar thing happens with older adults, not always as a result of abuse, but certainly because they're at increased risk of fall. So we start to see an increase in the amounts of subdural hematomas as someone gets older, because the brain shrinks in size as the person gets older. And so that head banging around inside the skull is more susceptible to having those subdural hematomas. We also see at this age a benign forgetfulness. And this occurs at any age. I have that. I'm sure some of you do. If we're stressed, we forget stuff. We forget where we put our car keys. Or we drive halfway to the store and remember we've forgotten our purse. Those kinds of things. But with older people, there is some benign forgetfulness. Now, I'm not standing here and saying that dementia is normal in older adults, because it's not. I'm not talking about that. There's a real difference in benign forgetfulness in dementia or Alzheimer's. Benign forgetfulness are one-offs. So forgetting where you put your keys, forgetting where your coat is, laying something down and not remembering, or going into a room occasionally and not remembering why you went in there. Does anybody ever do that? Yeah, That happens to all of us. Those are events of benign forgetfulness. When we see dementia, it's more a pattern, it's pervasive, and it's progressive typically. So the 3 Ps, that's a good way to think about it, versus benign forgetfulness. We tend to find that people, as they're older, it takes them longer to think about and process information. The information, if you think about the brain like it's a big file drawer, you think about it as processing and recall. Because our brain is very interesting in the way that we store information. As we process information, it gets stored categorically in our brain, and through chemical processes in the back brain, we're able to store it and recall it. If you ever have an opportunity to be in a surgery suite where they're doing a brain surgery and they stimulate different parts of the brain with electrodes, people can recall events verbatim of what they saw when they were 5, 4, 3, 2, very young children. So those things are all stored there, but the brain does it categorically. As we get older, these 2 things become more difficult. So our short-term memory may be affected. So forgetting where you put your keys 10 minutes ago, walking into a room, not remembering where you put things can be part of that. But also recalling recent information can be difficult because it stores it a little bit differently as we get older because the brain volume and the number of cells decreases. Motor responses become slower, people become less agile, the hands begin to look bony as a result of the atrophy of interosseous muscles. Also, you may see benign tremors at this point. This is because of the changes in some of the neurotransmitter function that control those movements are not quite as good. So sometimes you'll see people that have that little bilateral benign tremor. And they may also have a decreased sense of position. One thing that's really interesting about that is that while we're young, we typically move and bend, so we're bending over a lot more, we're bending side to side. What happens with the older adult? Do they do those things? Not really. And so what we start to see is kind of a stasis of a labyrinth in the middle ear that causes them not to be able to balance as well. And a lot of that is because they don't move around. There's a study done a couple of years ago about placing rocking chairs in senior care centers to improve that, because what it does is keep those labyrinths flexible and moving. If we find that somebody stays in an upright position, let's say they sit in a recliner or a geriatric chair all day in a nursing home, when you try to transfer that person, their balance is going to be off because their stasis in that inner ear. If we take that same individual and put them in a rocking chair where they're having to move back and forth, then that balance can be to some degree restored. So that's I thought you'd find that interesting. The one thing that should not change a whole lot, even though our response to it may change, that don't change with age are some of your lab values, red blood cells, H&H, BUN, creatinine, liver function tests, and T4. Those should not change. Abnormal values in these particular ones can signify normal age-related changes or reflect illness, depending on what situation or disease process we're dealing with. So again, you don't treat labs. Everybody has to be looked at as an individual. The comprehensive assessment is one of the things that defines geriatric care. Geriatrics cannot be done in 15 minutes. These are not going to be your quick visits. So if you find yourself in a clinic who's scheduling people who are in their 70s and 80s for a 15-minute visit, it's not going to work because you will be behind. The minimum amount of time you're going to need is 30 minutes. because they have to, number one, get in the door, get on the table, which may take them 10 minutes to get down the hall and get everything done. And because of that slower processing speed and recall, they're not going to be able to move through triage like someone who's in their 20s or 30s. It's going to take them a while to think about and tell you what's going on with them. One of the things that we did in our practice that as you move into management, you may observe in the practices you see is that we blocked our geriatric assessments around the time when the practice is least busy. So since we do have some pediatrics, we try to take them early in the morning because they all need to go home and have a nap in the afternoon. They're also sicker than our old people. And what do we know about older people's immune systems? Not so good. So we don't want them in the office with sick kids, right? So we try to schedule and block our visits around the needs of the populations that we serve in our practice. It may not always be an option for you, but you try to do it. Ask them always to bring their meds and their equipment that they're using with them. So if they're using a walker, make sure that they're bringing that you get to see them, how they are as much as you can in their home. But always, in our practice, we have what's called a brown bag rule. When you come to the office, we always require that they bring all of their medicines and vitamins in a brown bag. Sometimes that ends up being 2 or 3 shoe boxes. The thing you find about older adults is that they may have their medicines, they may have Aunt Susie who died's medicines, and they didn't want to waste it, so it worked for Aunt Susie, so I'm just going to take it too. So you want to see what they're actually taking. The other thing that's very important about the assessment of medicines in the older adult is to make sure you look at the dates of the fills on those medicines. That tells you about compliance in their medication, right? Okay. So those are things that are really important part of the comprehensive assessment is to really look at what's going on with them. Secondly, sitting close to and directly in front of the client, making sure that you're speaking in low, even tones that they can hear. And as I mentioned, you're not going to see an older adult in 15 minutes. It's not going to happen. Okay. When you think about the comprehensive geriatric assessment, there are 3 primary domains that we're looking at. We're looking at physical, cognitive, and psychosocial. And these are some things you're going to be looking at today as we move into our geriatric assessment. I'll be going over the tools with you a little bit later, but these are the 3 domains. We won't be doing physical assessment today, but we are going to be looking at cognitive and psychosocial. That's a little different than you would see with a younger adult. While we cursorily look at that, or if it's a specific chief complaint with a younger adult, with the older adult, these are the 3 domains that always have to be addressed. The other one is assessment for falls. You want to ask how many times have you fallen in the last month? That's the standard question. And if they say, well, I haven't fallen, but you don't want to say, did you fall? Because most of them are going to say no. And there's a lot of fearfulness about that question when you're working with older adults. Why do you think that might be? What happens to me if I'm older and I fall down? Oh, you're at the nursing home, right? Okay. So always ask, how many times have you fallen? It's often the way you ask it. Gait and balance training, strengthening exercises, reducing home hazards. The number 1 fall risk in the older adult's home is the fur rug that they got at the dollar store. Why is that? Doesn't have any rubber backing on it, does it? You hit that and what happens? You slide right off. Stairs are also another one. So talk about their environment and what type of safety measures. Asking them about, do they feel safe in their environment? Very important. And you always, with a fall in an older adult, want to try to do a little bit of forensics, kind of the CSI thing where you're figuring out what caused the fall. Because it could be medicines, it could be a balance issue like we were talking about with the labyrinthitis. It could be a lot of different things. It could be vision impairment. So always try to get to the bottom of it. Assessment tools that we use with the older adults can facilitate assessment of various aspects of functioning. Remember, it's not always about curing, it's more about function with the older adult, because we're not going to heal them necessarily. We're going to look at function. That's the key thing you're focusing on. Abnormal results don't provide diagnosis. Remember, treat your patient, not the labs, not the x-rays. It's all about the function. Some of the evaluation tools are your MMSE. I'll talk about those a little bit later, so we won't go into those. We're going to perform some of those today as we move into our assessments, but I'll talk about those a little bit later. And I see Dr. Rath has joined us. So I'm going to stop mine right here at the tools, because I am going to talk about those with you before we go out to do our assessment. Or you want me to go on? You have time? Okay. All right. Well, we'll go ahead and talk about them for a little bit, and then I'll talk about it again after Dr. Rath. The first one is the mini-mental status exam, and this is the Folstein mini-mental status. There's actually a version 2 that's out now, and it's electronic. This one is kind of the gold standard for assessment of mental status in the older adult, and a good indication of cognitive impairment. The one downside of this tool is that education does make a difference. People who have received a college education typically will score better on this, even with cognitive impairment. So you need to take that into account. In fact, part of the demographic information that you want to get when you use this tool is to find out what level of education they receive, because the scores will typically be higher, and if there's a cut point between cognitive impairment versus not, that person's going to score a little bit higher. The highest score you can make on it is 30. If someone is a couple of points lower than that, we don't worry too much about it. But when they start to get down in the 23, 24 range, we start to think about further diagnostics for that person. That's really part of another lecture, but suffice it to say is if they start to drop lower in those, with severe impairment, for example, if we were to perform a mini-mental on someone who has severe cognitive impairment, that score would be below 9 typically. The mini-cog is another one, and this is the one that I like to use in my practice because it's so easy to administer. Anybody can actually administer it. It's one that you'll be working with today as we go to assess or to spend time with the residents at both Sterling House and the Hamptons and learn from them. But the instruction on the mini-cog is use a 3-item recall. I decide on 3 words that I know I'm going to remember, because if you use different items every time, you will find that you may not remember them and your patient does. And it's pretty embarrassing when the clinician doesn't remember those. So I always use cut, ball, and pen. Those are the ones I know I'm always going to use. So I tell the older adult, I'm going to give you 3 items, and I'm going to, or 3 words, and I'm going to ask you to recall those in a little while after we talk about some other things. Remember, we talked about processing speed and recall being impaired in the older adults. So this is something that we are actually looking at with this exercise. So 3 words, and you tell them, we're going to talk about some other things, and I'm going to come back and ask you these words, so I want you to remember them. I always have the older adult repeat those words. Why would I want to do that? To make sure they heard them and that they understood them. We mentioned, as I told you about the little gentleman who was diagnosed with dementia when he actually had hearing impairment. It becomes very important to get this feedback from them to make sure they can repeat them appropriately to you. So I've given them the words. The next part of this mini-cog is the plot draw test. And what the instruction is to draw a plot. And set the time at 10 minutes after 11. I don't show them how to do it. There are all kinds of forms that you can use. Some already have the circle that's done. The one you have today will tell you specifically how to score it. But to suffice it to say, you're looking at the order of the numbers, the placement of the hands, and the drawing of a full circle. With someone, and this is a very good screen for cognitive impairment that takes less than 2 minutes to do. So it's one that I like to use with older adults and keep in their chart because it is such a good indicator for the need of possible further assessment if we find that there's a problem. With someone with mild cognitive impairment, sometimes you'll see things like a repetition of numbers. And it'll look something maybe like that. You can see it's not real bad, but there's a little bit there. With somebody who has moderate impairment, we might see something more like that, where the circle's not joined. This. And with severe impairment, typically you won't even see the closure of a circle. Sometimes they may even refuse to draw the clock. But once they've completed that, and this correlates, as I wanted to tell you, with the mini mental status exam. So this score would be, could be lowest, say 24, 25, so we'll say 25 to 30. They might not recall all these. This would probably be less than 24, and this one would probably be 10 or less. So that kind of gives you an idea. Those do correlate very closely, though. But once you've asked them to draw the clock, then you go back and say, okay, remember those 3 things that we talked about earlier, those 3 words I asked you to remember? Then you would check processing and recall with those. So it's a very thorough exam that takes just a few minutes to do. The thing that is an advantage over the mini-cog versus the MMSE is this is very little related to their educational level. This gets right to processing speed and recall. So it's actually, I like it in some ways better, although the gold standard continues to be the MMSE. And now that the MMSE 2 is out, it's one that's considered more appropriate. In your practices, you may see an increased screening for depression, and the PHQ-9 is one that you may already be using in your practices that you're out in. I don't know. But the Geriatric Depression Scale is one that is very useful as a screening tool to measure affect in the elderly. And the score of 0 to 9 is normal. We'll go through that tool a little bit more later. But a score of 10 to 19 can indicate mild depression, while a score of 20 to 30 on the questionnaire indicates severe depression. You can Google Geriatric Depression Scale and it'll come up. It's been a gold standard for a long time, but it's sad to note that about 60% of institutionalized elders are depressed and they've gone untreated. So we as a medical community have not done a very good job at diagnosing and treating depression. The SPICES assessment tool is another one that looks at common health risk of the elderly, and I'll again show you that a little bit later, but it really looks at common problems that we see as health risk in older adults. So we'll look at that and talk about that a little bit more specifically when I come back at 11 after Dr. Rath lectures. But it really identifies for health risk, so sleep disorders. P is for problems with eating or feeding. I is the incontinence issues that we talked about earlier. C is confusion, and I also ask about memory when I ask about this. E is for evidence of falls, again asking how many times they've fallen in the last month. And of course S is for skin breakdown, as we talked about. The CATS ADL assessment scale, if you're doing a full comprehensive geriatric assessment or you're working in a geriatric focused clinic, we do some geriatric house calls and so have an adaptation of this in our electronic medical system, but you're looking at their ability to live independently and to perform ADLs. So this is measured on what the patient is actually doing, not what they say they're capable of doing. Okay? That's really important to remember about the scale. And it's really important to remember about your geriatric patients. There's a lot of fearfulness about being placed outside their home. And so very often we don't get accurate responses. So the CAT scale is something that we want to really, sometimes you have to involve family members or caregivers that take care of these individuals to help you get accurate assessments of these. But it's based on what the person's actually doing, not what they say they're doing. IADLs are, of course, higher level abilities like phone, shopping, housekeeping, and some of these. This is another one that's used in the home setting to really look at decline and what if needs are being met in the home. The other thing I would tell you about working with geriatrics is that atypical symptoms are common in the elderly. In fact, that's often the rule. So when somebody, for instance, has you have an older adult with scabies, and we all know what scabies looks like, kind of a crusty, itchy red stuff. In some people, it doesn't look like that at all. It'll look like a pinpoint rash. Why would that be? So we talked about earlier that would make the response different in the older adult. The immune system function. So we may not see it. That's also true of diseases like pneumonia. The only complaint you may hear from an older person who has pneumonia is that they feel tired. They may not have a fever at all. May not have any symptoms. Pneumonia has, in the past, and when I was in school, was called the old man's friend. Why would that be? It just takes you out peacefully. You should just get tired. Your lungs are already compromised when you're older, and as the pneumonia consolidates, your OT sat goes down. It doesn't really bother you, and you just pass away. So, and it often is it's unnoticed because there's no complaint that the person has. So that's one of the things that makes geriatrics so complex, because they have typically more than one thing going on, so you have to ferret out what it is that's the problem, or whether it's polypharmacy, or whether it's the natural course of aging, or if there's something really wrong, like someone has pneumonia. Health promotion is another important part of taking care of older people. And this is, again, all about function. If I haven't gotten through to you on anything else in the lecture, remember, older adults, all about function. It's all about function. Activities that decrease symptom intensity include improvement of their nutrition. So looking at nutritional status. Remember the lady I talked to you about that was having congestive heart failure symptoms and ending up in the hospital every year. It was about resources in her case, wasn't it? She went into the donut hole on meds and was buying cheap tomato soup to make it through the winter, and so she was ending up in the hospital. So those are some of the forensics that you have to do. Cessation of smoking. This is another one, and in this part of the country you also have to look at dipping and chewing, because those are other things that people do. The other thing that we have seen an increase in older adults is with alcoholism. People who, because mental health services have not always been the best, especially in rural areas, or the long wait times, or meds are very expensive, sometimes people choose to medicate with alcohol. And so that's another huge problem. We've seen withdrawal symptoms in alcohol when we placed people in nursing homes and assisted livings because nobody knew they were drinking. And they went into the nursing home or the assisted living and couldn't get to their alcohol, and so went into DTs, and we didn't know that's what it was.
I've had several older women that are actually of a more affluent status
Mm-hmm.
come into the hospital and they begin to have changes and come find out they have an evening toddy
Mm-hmm.
every day.
That's right. That evening toddy can sometimes turn to 2 or 3 drinks in the evening. That's a good point because, some people, especially if they have cognitive impairment, may say, well, I've always had my evening toddy, but if you're forgetful and you have a progressive dementia, you may forget you've had that evening toddy, and it might be time to have another, and another, and another. And so those are certainly things to explore. We can't assume because someone's older that these kinds of issues shouldn't be talked about. This goes with drinking, smoking, sexual activity. One of the populations where we're seeing the biggest increase in HIV is in older adults. In fact, these communities in Florida, and we're starting to see just a real increase in sexually transmitted diseases and in HIV in that population. So those are things that I always ask about. I'm sure if I haven't told you, I'll tell you that, or if I have, you just have to forgive me. It's probably because I'm getting older. There was a little gentleman that I took care of. It's been a number of years ago, and I always avoided asking older adults about sexual activity. So I thought, well, that's not really something I should be asking these little grandmotherly sweet people. And this little man was adorable. He always came in his little coat and tie when he would come to see me. And I noticed he had come several times. He had just got out of the hospital with an MI. And he came 2 or 3 weeks to see me for just non-specific complaints when I was at this community. And I couldn't figure out what was going on. And so finally he got brave enough to say, well, because I asked him, Mr. Williams, what was wrong? And he goes, well, I have a little girlfriend here, and sometimes we get together. I said, oh? And he was worried that sexual activity was going to give him another heart attack. But I didn't ask him about that. So shame on me. He had to make 3 trips to see me before he was willing to even go that far with it. Very sad. So people, as I mentioned to you earlier, one thing we tend to forget about is even though there's an 80-year-old body, there's still a 20-year-old spirit inside that package. So people still have those desires. And you may think, well, what's this sweet little 80-year-old man doing? Well, he was doing some serious romancing. So, it's something that I should have acknowledged because it was very important to him, and I didn't bring it up at all. So shame on me. So learn from my mistake. Okay. Primary prevention, of course, immunizations are very important is another aspect of care. Make sure that people get their pneumonia shots after age 65 if they've not had it. After age 60, shingles. Be sure you keep up with those immunization schedules. Tetanus is another one, especially if they're at home, that we want to make sure that they get. These little folks out here in East Texas love to garden, and they think once they're out of grade school they don't need a tetanus shot anymore. So we have to make sure we ask about those kinds of things. Pneumococcal vaccine is there, and of course, if the vaccine was given before the age of 65 and 5 years has elapsed, we have to give another one. Influenza every year, and you get a lot of pushback out here in East Texas about that one. It's my Uncle Joe took that flu vaccine and he got the flu. Well, you might, but the bad thing about flu nowadays is that it is such virulent strains that these people will succumb to it. The very young and the very old are very at risk for the influenza strains that are out now, and so I try to make sure that these immunization series stay up to date. Medicare does pay for flu vaccines, so definitely available. They can get them at the pharmacy if they don't want to come to you and get them. Focus on early disease detection. So again, there's screenings that have to take place, mammograms, cancer screenings, management of obesity. A lot of people start to drop these as they get older. Probably the number one most resisted screening there is the colonoscopy. But this is something that we definitely want to do for our patients. Prostate exams are probably the second most resisted thing, but equally important. And mammography. And you'll notice here in this guidance that this is included to age 74 or when life expectancy is less than 4 to 5 years. Tertiary prevention in the older adult focuses on reducing the discomfort and maximizing function. Screening and treatment, as we've been talking about, for dementia, depression, and incontinence. And then, as I've talked about earlier, because everyone ages at a different rate and people have different processing and recalls, geriatrics is very, very individualized. It's probably one of the most autonomous types of practice that we have, and if you enjoy CSI or those kinds of programs, you'll enjoy geriatrics because it's a lot about investigation and it's a lot about creativity. They're actually a interesting population to work with. They can sometimes be frustrating to work with, but you'll never be bored. So I thank you for your time this morning. I'm going to turn it over to Dr. Rath, and then I'll be back later, and we'll go through the tools that we're going to be completing later.
Johnny, take